Good afternoon. Thanks very much to all of the organizers of this meeting. I'm very, very happy to be here and participating today. My vantage point is from a 95-year-old national organization that has continually worked to improve the quality of maternity care on behalf of mothers, babies, and families. And as Holly mentioned, our current focus is primarily on strategies of consumer engagement and health system transformation. And soon I'll share some guidance with you from our Transforming Maternity Care project, which engaged over 100 leaders from across the healthcare system. And some of those are here today on both the program and in the as attendees. And this was to develop 2 consensus documents. So within this vast topic of process of care during childbirth, I'd like to ask 3 questions. What intrapartum care principles and processes are optimal for healthy, lower-risk childbearing women and newborns? Because those are the group we can think of possibly moving across these different settings. What settings most reliably implement these principles and processes, and what criteria should be used to assess intrapartum care within and across birth settings? So to ask about the optimal care for this population during childbirth, I would like to share with you some insights from our Consensus Report 2020 Vision for a High-Quality, High-Value Maternity Care System. Now, we had a multidisciplinary, multi-stakeholder team. We provided them in advance with best evidence about different elements of the maternity care system. The team met together for a facilitated meeting, continued to work by email and phone, and then their draft document was peer-reviewed by all members of our Transforming Maternity Care Project Steering Committee and all 10 co-chairs of our stakeholder work group. The final report describes the values and principles that you see here, which include adapting for maternity care, the 6 quality chasm aims, clarifying that care processes should be protecting, promoting, and supporting physiologic birth, and ensuring that practice is well aligned with best evidence. So also consistent with the quality chasm report was our definition of quality, the degree to which maternity services increase the likelihood of optimal health outcomes that are consistent with current knowledge. And I'm going to read to you just 2 excerpts from this consensus document. All maternity caregivers have knowledge and skills necessary to enhance the innate childbearing capacities of women. Each woman is attended in labor and birth in the manner that is most appropriate for her level of need and that of her baby, and experiences only interventions that are medically indicated, supported by sound evidence of benefit with least risk of harm compared with effective alternatives. Women and babies at high risk for complications for whom a higher level of specialized care is appropriate have specialty care available to them that adheres to the same basic values and principles. And a statement about the care system and settings for care around the time of birth. A full range of safe birth options is available and receives system-wide support so that each woman is free to choose the setting that is most appropriate for her level of need and that of her fetus baby, and that best reflects her values, culture, and preferences. This choice can be made with confidence because each setting assures her a consistent standard of safe, effective, risk-appropriate care within an integrated system that provides for coordinated consultation, collaboration, or transfer in either direction should her level of need or that of her baby change. So to consider optimal childbirth care, I'd also like to share with you the essence of a commissioned report on the hormonal physiology of childbearing that we will be issuing this spring. And a large body of evidence finds that when, and this is borrowing from the breastfeeding community, protected, promoted, and supported Endogenous hormone systems optimize physiologic adaptation of mothers and babies from before the onset of labor all the way through to breastfeeding and attachment. And benefits would include helping with stress and labor pain, providing fetal neuroprotection, reducing the likelihood of postpartum hemorrhage, and optimizing the initiation of breastfeeding. And in this report, conversely, we're getting a body of evidence that clarifies that common maternity care interventions can disrupt these processes and interfere with these benefits. And related to this, and we've alluded to this earlier today as well, is the burgeoning literature on the developmental origins of health and disease. So we increasingly understand that medical, nutritional, and environmental exposures during sensitive periods of rapid development can have lifelong consequences for immune, metabolic, neurologic, and other bodily systems, including epigenetic effects. And very sobering for our field should be the studies where we have seen multi-generational effects relating to DES. Now, some of these studies here that I've included clarify that these effects can vary by birth setting, and also and generally the less intervention, the less adverse consequences, and they vary by factors that vary by birth settings, such as mode of birth and infant feeding. And it's important also to note that mothers experience lasting or lifelong effects from care processes as well, and this is really impressively documented around cesarean sections and breastfeeding. And I want to also say that I'm a little uncomfortable saying the baby and the mother because, of course, it's a really interconnected dyad, and that's how some of these frameworks need to be looking at that. So as not to overstate the evidence, I would like to refer to a mosaic that is coming into view, showing that undisturbed physiologic childbearing confers benefits to mothers and babies, and that common practices can have many consequential, sustained, and unintended consequences. And this raises concerns about what we know, what is incompletely known, and what is completely unknown to us at this time. So my response is to say that it would be very prudent for us to exercise the precautionary principle, and whenever possible, minimize the deviation from our mammalian heritage and limit exposure to interventions when they're clearly indicated. So moving on to the question of what settings most reliably implement these principles and processes, I would like to refer to our report on evidence-based maternity care, where we looked at what the processes were that mothers and babies were experiencing, and we were able to pull a lot of data from our National Listening to Mothers survey of women who gave birth in U.S. hospitals in 2005, and we compared that to the evidence and results from systematic reviews about care practices that are experienced by a large portion in this population. And an update is due on this, and I'm very happy to say that we'll soon be releasing Listening to Mothers 3, and hopefully we'll get the bandwidth to update this particular analysis. But I'm happy to refer you to our previous report where we lay out the case for calling these overused practices in our system right now: labor induction, epidural analgesia, cesarean section, and the others that you see here. And conversely, we identify quite a few practices that are effective, beneficial, low, non-invasive, and in some cases have very few or even no identified downsides. And this would include midwifery care and family physician maternity care, smoking cessation interventions, version, and the others that you see here, as well as non-supine positions for giving birth, delayed cord clamping, early skin-to-skin contact, and the other interventions that you see here. So Now I'm going to, well, first of all, just I think these over and underused practices are raising concerns about whether hospitals are providing the optimal care for the majority of childbearing families. And now I'd like to look at several studies, and my purpose here is not to assess the weight of a body of evidence or to identify very precise estimates, but to find studies that help us to clarify, are there really differences in practice style across these settings? And the first one, looking at hospital comparisons with birth center care, is a secondary analysis of the first national birth center study, comparing those participants with a group of women experiencing care in hospitals. Both of them had predominantly midwifery care, and they had no medical or OB risk factors as defined by the investigators, and no prenatal or intrapartum complications. So this would be a poor study for assessing outcomes, but it's a great study for trying to look at the differences in care. And as you can see here, all 8 of these items are differed and favored the group receiving birth center care. A second study, and the reference is on the next slide, looked at birth center women who had received midwifery care compared to women in hospitals who had received physician care, but those women would have been eligible for birth center care. It was an intention to treat analysis, and further, it adjusted for quite a few factors that you see here. And in this case, all 11 of these interventions and care practices favored the birth center group, and that conservative style of care did not result in a compromise for the outcomes around a whole series of important outcomes, and in fact several were favored in that group. And finally, there's the Birthplace in England study, which you've already heard, and just to say that the odds ratio for birth center versus obstetric unit care for that normal birth measure was 3.86 in that study. Now moving to care with home birth, Dr. Wax and his colleagues compared hospital and home birth and found differences favoring birth center for these 5 high-impact interventions that you see here, and for these 5 consequential outcomes that you see. There we go. Perineal laceration favored the hospital birth, but a measure that's of great importance to women is intact perineum, and when we factor in episiotomies, very often we find that that favors the home birth group. Cord prolapse was not different. Several fundamental outcomes of importance favored home birth. A couple of others were not different, and a small absolute risk difference in neonatal deaths favored the hospital births. Now, this has been a very controversial outcome with a number of concerns discussed in the literature, including the inclusion of women with unplanned high-risk births in some of the studies that were included. But what is absolutely clear to me regarding safety issues is that we don't have an integrated system right now, and we need one in the U.S. that does such things as look at licensure of all providers, electronic sharing of records, routine care collaboration, routine performance measurement and reporting, and quality improvement. Again, Birthplace in England, this time the odds ratio was 4.47 for that normal birth measure. And to just briefly discuss criteria that should be used to assess intrapartum care across birth settings, we need to look at outcomes of interest to women and families that are often excluded from our studies, and you can see some here: quality of life, physical and emotional functioning, and so forth. We need to look at optimal outcomes, such as that normal birth measure, spontaneous vaginal birth, exclusive breastfeeding, as well as harms. And I've identified a series of important harms here. They're understudied in medicine generally and in our field. We need to assess whether they're providing physiologic care. Do the personnel have the skills and knowledge, and are they doing their providing appropriate prevention of the disruption of these processes and supporting of the processes? Another problem is follow-up beyond the intrapartum period. We have a long episode of care for a vulnerable population. It's costly, and we basically have a black box in terms of what are we getting at the end of the day. So that is an urgent need moving forward. And experience of care, the CAPS generic surveys of a hospital do a very poor job of translating to this population. There's nothing about the baby, and it's very poor and inadequate looking across settings and across types of providers among many other areas. And finally, many women have access finding ready and willing services that should be routinely available, such as VBAC, version, vaginal breach in twins, and others. So when we are assessing settings, we need to ask whether they competently provide essential maternity services appropriate to their level of care, and whether they are truly offering and supporting women's informed choices. So the summary points are: the precautionary principle is a prudent consideration when assessing processes of care during childbirth. Hospitals are much more likely to provide the type of childbirth care needed by women and babies at higher risk or with significant established problems than by most lower risk childbearing families. Care around the time of birth in birth centers and home births appears to be more closely aligned with needs of lower risk childbearing families, but our broader healthcare system needs to better integrate and support these settings and hold them accountable. And current research cannot answer many priority questions about the comparative effectiveness of childbirth care in birth settings. Thank you very much.
Thank you, Carol. These have been great presentations. Our last panelist is Dr. Esther M. Sternberg, who's a major force in mind-body stress wellness environment research and on the interrelationships of those four areas. She's published several books which are in your biography. They're very, very interesting. And she's hosted the PBS series, The Science of Healing. Dr. Sternberg was recognized by the National Library of Medicine as one of 300 women physicians who've changed the face of medicine. She's the research director for the Arizona Center for Integrative Medicine at the University of Arizona, Tucson, and was previously the section chief of neuroendocrine immunology and behavior at the National Institute of Mental Health. She's going to help us understand how the structures and environment in which women birth might affect their health outcomes and their future. Thank you. Please welcome Dr. Sternberg.